Oh, hello, hello. Good morning. Happy Thursday, everybody. Welcome to yet another VMR. As you likely
Mhm.
are becoming accustomed to, Thursday is a very special day where I get to co-discuss with one of our team members. But before I tell you that, I wanted to emphasize to you just how important it is that just how important each and every single person who's listening to this is. This is a community that exists and revolves around medicine, but it actually exists and revolves around people injecting their medical cases. And that's really the fuel that keeps this going. No cases, no VMR, no VMR, and a lot of things, medical and otherwise, collapse. So I really, really, really wanted to take a moment to emphasize that we are hoping to encounter, meet, and learn from every single one of you. If you've taken care of a patient with anything at all, I really, really encourage you to consider presenting it. And the way to do that is actually not to go solo by yourself. You can if you want, but to lean into the incredible team that we have that can guide you through that process. So let me show you how to do that if you're interested. You just go to the clinicalproblemsolving.com, which is our website. Then you click on morning report, which is this. Once you click on morning report, you'll have two options to either sign up and join us live, which you should definitely do, and how to present a case. These are very, very simple forms that you can fill that will really help everybody involved. You learn and grow, and us continue to learn and grow as well, but more importantly, to connect and to deepen this community. Um, I say that because yet again, we're leading on the case review community and our community building this time from Emory to introduce, sorry, our case presenter. But before we do that, I want to thank two people who are making this happen. The first is Vinny, who is helping us subscribing today. I'll pass the mic to you, Vinny, to say hello.
So, hey everybody, I'm Vinny. It's a pleasure to be scribing today. That's it.
Thank you for you're known for your brevity, Vinny, but it does not fool me. The depth of your wisdom is deep. Parisa has been doing teaching points for so long that I realize in my mind I have a name for it. It's called Pearls with Parisa. She's hosting yet again today. Parisa, say hello, please.
Hello, everyone. I'm doing teaching point today. This is Parisa.
Again, the brevity is incredible. I think the brevity is in large part because Parisa and Vinny just want Noah to completely sit and bathe in the spotlight, and I think he deserves that very, very, very deeply so. Uh, I think no one knows this, but maybe the rest of you don't. Noah was actually the inspiration, and his session was the inspiration behind the CP Solvers Academy. And the little mini story behind that is Marcella, who is here, had already established herself as one of our incredible team members, and she was like, "Hey, I know this guy Noah. He's kind of cool and smart. Why don't we do a session with him?" And Noah came and presented an unbelievable case of granulomatosis with polyangiitis, but the manner in which he presented it told us all about who he is as a person and how much he loves medicine. And now, as a rock star intern at WashU, he's absolutely crushing it, and still somehow manages to find time to share with us at least a case per day, while as a busy intern. So I couldn't be more excited. I think Noah is the future of CP solvers. He'll probably take my seat 3.5 days from now, at his pace. Super excited, Noah. I'll hand the mic to you to say hi, and then we get to introduce our case presenter.
Hey everyone, thank you for the kind words, Rabih. Thank you for the introduction. It's crazy to look back and see that's been more than a year now. It's like almost 2 years since I presented that case. And ever since I presented it, I just fell in love with CP Solvers, such a welcoming community, people like sharing love for medicine. And, I feel like it recharges me instead of like being more work. I come and I tell about the cases and like we all learn together. So it's a great community and I'm very glad to be a part of it.
Gosh, a part of it is underselling yourself, my son, my friend. You are becoming a pivotal part of the entire orbit. But I think your infectious enthusiasm for medicine is met by our case presenter today, who has decided to present on his week off. Um, And I know that people have conflicting feelings about that. I personally think it's an absolutely incredible thing. And so I'll hand the mic to our case presenter, Daniel, to say hi and tell us a little bit about yourself.
Well, hey everyone. I'm just so excited to be here. Thank you so much for the kind words. I love everything about this podcast and what you guys are about on this platform. I'm Dan. I'm a second-year internal medicine resident at Emory. I just love to be here. This is now my third time presenting one of these cases. I've got two more lined up. I love the mission you guys have of democratizing medical education. So I'm just so excited to be here with you all. Outside of work, I love running. I love eating food with Yusuf when he's free. But just so excited to be here with you all.
That's so cool. Daniel, Dan, I'm sorry. Where do you and Yusuf typically, if we were to find you together, where would you be?
So we've been going to Korean barbecue places around town. Yeah, exactly. KBBQ places around town. But I'm always looking to try new places. So wherever he texts me, we're going.
Well, I love it. Hey, there's nothing that Yusuf has ever said or advised in my entire existence that hasn't borne true. So
Yeah. Yeah.
I'm excited, really, really excited for round 3, and I know you have 5 cases lined up. And if my wishes come true, we will resorb you into the CP solver space, such that you never ever leave. But we're very excited for round 3. Take it away.
All right. Let me jump right in to our discussion. So we're starting out today with a 26-year-old woman. She has a past medical history pertinent for class 3 obesity, and she is presenting with around 4 to 5 days of epigastric pain that is described as severe. So the patient is just describing to me that this pain has been progressing now over the past several days. It's mostly located in her abdomen, but she does report that when she leans forward, some of those symptoms are resolved. And she says that anytime she has a deep inspiration or exertion, she has worsening pressure feelings. She also endorses persistent shortness of breath, a non-productive cough that has now been going on for about a week, and some hoarseness and nausea. Of note, she does deny any recent fevers, chills, any lightheadedness, diarrhea, or any other overt infectious symptoms. She also does not report any recent sick contacts. And some other relevant history here. She only has a history of class 3 obesity, no other medical conditions. She has no prior surgeries. And in terms of family history, she has a mother who died in her 40s of triple negative breast cancer, but no other family history. In terms of social history, she lives alone in an apartment. She does not endorse any tobacco, alcohol, or IV drug use, and she works as a member of the Child Protective Services here in Atlanta. And finally, in terms of medications, the only medication she takes is famotidine 10 milligrams as needed for intermittent heartburn. And I will stop there.
Oh my gosh, presenting like a pro. I absolutely love it. Thank you so much. Noah, where'd your head go with this?
It's a very interesting aliquot, and I think illustrates an important concept. Because if I heard only 26-year-old female with 4 to 5 days of severe epigastric pain, the way I would approach it is by focusing on abdominal pain for sure, right? And then immediately thinking of the hypopneumonic is a good way to think about very serious and emergent causes. So vascular etiologies, inflammatory, perforations, and obstructions. And then anything can happen in the abdomen, and we know that the location isn't really a good discriminator of the etiology. So you can just think through every single organ and apply the hypopneumonic to it, and basically you have like a very extensive differential diagnosis. But as we've learned in many VMRs, we always have to look up and look down. So we always look to the GU, we always look to uterine vaginal causes of abdominal pain, especially in a person that's young and is probably of still menstruating, still being of childbearing age. And we always look up to lower lobe pneumonias, to PEs with infarctions, and in this case, with this quality of pleuritic chest, maybe epigastric pain, even the pericardium and the mediastinum. So that's where my mind goes. I think that the fact that the pressure relieves when laying forward, it's classically associated with pericarditis, and the associated symptoms also give us a clue that maybe the abdomen is in the best localization, is in the best center of gravity for the syndrome. Maybe something more towards the lower portion of the chest with the shortness of breath, cough, hoarseness, and a very non-specific nausea. What do you think, Rabih?
Yeah, no, I absolutely love it. I think that you're taking the chief concern and you're trying to understand where it lives. And then after you make some progress on where it lives, you're trying to decorate that with the other accompanying symptoms. And so it's really very powerful to see you not just get so much juice out of the associated features of the epigastric pain, but also to emphasize how that is really the center of your analysis, and the other things, the nausea, the hoarseness, are things that you're using as secondary pieces. And I completely agree with that analysis. And I think that your cautionary tale of epigastric pain not always living in the belly is really, really powerful. And I think one other thing that reinforces the notion that it might not live in the belly is a lack of vomiting, even though she's nauseous. If you're expecting patient to have gastric issues or pancreatic issues or biliary issues, oftentimes when the pain is mild, the nausea and vomiting may be mild, but for the pain to be described as severe without emesis at least once is really interesting. And I think is another thing that reinforces the direction that you're going. But it goes to show how you have to be careful, and you'll be very, very wise once you know where the epigastric pain is coming from, to decorate everything else. And right now it's purely speculative. But I'm curious, if you are taking a leap of faith for a moment that this is in fact a pericardial story, what which I'm just biased a little bit having been there on Monday. So if we're doing the pericardial theme this week with with Dan, I think that'd be pretty funny. But I'm really curious what you do then with those decorative pieces. The patient has cough, hoarseness, nausea. Are they non-specific and just reinforce the pericardium, or do they take you a certain distance away from that hypothesis?
I think that, if we're thinking of pericardial disease, and in this case, with this acute presentation, I would think more of like an acute pericarditis, and then going through the differential, like autoimmune causes, or maybe post-infectious, or even actual infectious. The shortness of breath, cough, hoarseness could be a pointer towards like a URI trigger to the pericarditis. Or we could have another pleuritic process, not necessarily in the pericardium, but in the lung pleura. And the shortness of breath, cough, and hoarseness could help us localize it to the respiratory system instead of only the heart. So I do think, it's just like something's wrong around that area, between the stomach, the heart, and the lungs, right in the center behind the sternum. And the differential is still pretty broad. And I'm not convinced that just based on those, as you said, decorations, I wouldn't put my money down quite now. I would just keep it very broad.
Yeah, no, I completely agree with you. I think the leap that you're done is you said epigastrium, pericardium. And then the hoarseness is really a neck symptom. And so like, how do you connect the hoarseness to the pericardium is one very simple explanation, which you outlined, is the patient could have a post-URI idiopathic pericarditis. The other thing that could be happening is that the pericardium, or a mediastinal structure, as you said, is occupying space in the mediastinum and compressing the recurrent laryngeal nerve. So I think that the thing that's intriguing to me about this case is the simultaneous onset of all these symptoms at the same time. And the vast majority of patients who have idiopathic or post-URI pericarditis, the signature of the upper respiratory tract infection is long gone. And it's often a hypothetical exercise to say, oh, this is a post-viral one. So I, like you, I'm very suspicious of the pericardium, and I'm intrigued by the fact that there's also a neck symptom. And does that mean that there's disease in the neck as well? Or does that mean that actually, no, the mediastinum and the pericardium are radiating into the epigastrium and radiating into the neck via the recurrent laryngeal nerve? So are we dealing with something from neck to abdomen, or a very strategically located entity in the pericardium that's actually causing referred dysfunction? So that'll be, I think, one question that we'll have to answer. All right. Anything else you wanted to sprinkle in before we hear more from Dan?
No, I think that was very good.
Awesome. All right, Dan, tell us more.
Awesome. What an incredible discussion. That was just a phenomenal overview. Great discussion. Okay, let's get into some more details. So in terms of the patient's vitals, the patient had a temperature on admission of 36.4 Celsius, a heart rate of 102, respiratory rate of 16, and a blood pressure of 156/74, sitting at 95% on room air. In terms of the patient's physical exam, the patient was awake and well appearing, in no acute distress when I first approached her. She was normocephalic and atraumatic. However, she did have distended neck veins that I appreciated up to the mandible. Additionally, she did have a regular rate and rhythm. She had a normal S1 and an S2, and I could not appreciate any murmurs, rubs, or gallops. In terms of pulmonary, she had no increased work of breathing. Her lungs were clear to auscultation throughout her bilateral and anterior lung fields. Her abdominal exam was actually non-tender. The abdomen was soft, non-tender, non-distended, and there were bowel sounds present. Her extremities were warm and well perfused. There were no signs of edema or cyanosis. Her skin did not show any signs of rashes, bruises, or wounds. She was A&O ×4. She had no gross neurodeficits, and she was very cooperative and had an appropriate mood and was able to converse appropriately. And I will pause there.
I gotta tell you, this exam is unreal. And I will just call out how hard it is to notice distended neck veins in patients with class 3 obesity, and your ability to do so, I think, is a game changer in this case. So kudos to you for doing that. It helps us a lot. Or maybe I'm being presumptive. It helped me a lot. I'm curious. What are you thinking, Noah?
Yeah, I really like the exam. I think that if I'm looking just at the vitals, I'll be falsely reassured. I think this patient is at high risk of decompensation just because of how acute this process is and how sensitive to pressure overload the pericardium is. So we're already seeing signs that pressure is being backed up and the neck veins are being distended. And if this can progress, it's just a matter of time that the blood pressure start to fall and she start to decompensate. So I think we're falsely reassured by the vitals for sure. And one thing that I do think it's a pertinent negative in the physical exam, besides, the obvious non-focal abdominal, like very benign, is the lack of rash. As people were saying in the chat, some viral entities can cause both rash and pericarditis. So I think that's that's good that the team picked up on it and looked for it intentionally, because it's easy to miss when a person comes in with abdominal pain. You're not looking at their hands. You're not like doing a full skin review. Yeah, so those are my initial thoughts.
Absolutely superb. I think one thing that's very illustrative of the power of the history is to do an exercise together. And I'll ask all of you to think about what might happen if a very common scenario where you walk in and you actually, before you talk to the patient, see the vital signs on the screen and actually notice the neck veins before the patient has uttered a word. So Noah, let's do that exercise together. So pretend you have all the information you have is just the vital signs and the physical exam. That's only appreciable from observation, so distended neck veins. What do you think you would call the problem that you're able to gather from just that information alone? What do you think?
Just the vitals in the distended neck vein?
Yeah, what would you call that?
And we don't have any story. We don't have any. Okay,
No.
this is actually an interesting exercise because I have a patient just like this on cardiology floors, and like the differential is pretty broad, right? This could be, you know, this to me is like systemic congestion. It could be just localized congestion as well, like superior vena cava syndrome. But it could also be like very severe tricuspid regurgitation, which is the patient that I have. So like right-sided congestion. Yeah.
Yeah. I think that's a very wise label that you just said, right? You're noticing the information that you have, the patient's not tachypnic, so adding 95%, yet has distended neck veins and tachycardia. So if I think you walk in this room, you're like, whoa, this patient looks like they have predominant right-sided heart failure, right? Just from that story alone, or those observations alone. So then you would probably, without the history, ask yourself, wait, what causes isolated right heart failure? So without the history, what do you think you would say? Okay, I'm locked into this as isolated right heart failure. What would cross your mind as potential causes?
I'm very biased because I'm seeing a lot of pulmonary hypertension patients. So that's the big category for sure. Also, any valvular problems on the right side. We had a good case in the clinical unknown about serotonin syndrome, so like tricuspid stenosis, tricuspid regurgitation, infectious endocarditis are good causes. This case, you know, with those vitals, I think it's out of proportion, like the right-sided failure versus the left. So I'd expect crackles and like heart being more dyspneic if it was due to left heart failure. So that's why I'm not mentioning it. I also think respiratory conditions in general, but again, 26, unlikely to have such severe OSA or COPD that causes such bad pulmonary hypertension to cause like cor pulmonale.
Absolutely superb. I think that I just want to make a point, and my job is to give you more clarity on what you already know, which is just make note of the fact that most causes of right heart failure have nothing to do with the heart. The most common cause is referred transmission of pressure from the left heart. We talk about that all the time. Left-sided disease radiates back to the right heart through the pulmonary circulation. Nothing to do with the right heart intrinsically. Pulmonary hypertension, nothing to do with the right heart intrinsically. And lastly, pericardial effusion, nothing to do with the right heart intrinsically. The vast majority of causes of right heart failure, especially in the absence of left heart failure, are external pressure on the right ventricle, either from an encapsulating pericardial process or a choking off pulmonary artery process. The right heart muscle is usually not the culprit. And both those circumstances, and this is a concept, it's hard to elaborate on it in these spaces, but for folks who are part of the academy, will become familiar with the idea that this is a pressure overload phenomenon. And I'll just leave it at that for you to reflect on to see that the patient has hemodynamic features already. How many patients with heart failure have you seen who have a heart rate of 102? Very, very unusual. So if you're seeing heart failure and tachycardia, I hope it's an arrhythmia, because if it is actually sinus tachycardia, it is a very ominous sign for a pressure overload phenomenon, either a pericardial effusion or pulmonary hypertension. And I think the only advice I would have is to keep pulmonary hypertension in your mind, which is why we did this exercise, even though the history is screaming at pericardial effusion. And the reason to do that is twofold. The first is that it's not uncommon for pulmonary hypertension and pericardial effusion to coexist, either because of an underlying systemic disease, and the hint to that is the exact same disease that Dan presented on Monday can actually cause pulmonary hypertension and pericardial effusion. And it's very, very easy to get distracted by the presence of a pericardial effusion on a bedside ultrasound and forget that the patient might have pulmonary hypertension. But the relationship can also be that a pulmonary hypertension is driving a pericardial effusion through elevated coronary venous sinus pressures. And knowing of that possibility early on is really important, because it actually really causes a tremendous amount of management dilemmas. And the idea being that a pericardial effusion may actually be of benefit for the patient to counteract the high pulmonary pressures that they have. So if you think about what's happening to the right ventricle as it fatigues and balloons out from high right ventricular pressures from the pulmonary artery, the presence of an external massaging device can help counter that. And so it is actually very well described for patients who have pulmonary hypertension-induced pericardial effusion to have pericardiocentesis, not knowing that pulmonary hypertension is the cause, to be followed by immediate cardiovascular collapse. So two things here. The exam is very telling, as you said, and everything that you said is absolutely true. And I would just emphasize, when you're thinking right heart failure, think there's something outside the heart that's the problem. And no matter what, don't ever let go of pulmonary hypertension, even when the case is a pericardial story, not just because of CP solver's coolness that could be lying underneath causing both, but because of the practical implications of missing pulmonary hypertension in a patient with a pericardial effusion. So I think we should probably hold on to both of those stubbornly until we can exonerate them. Any questions about any of that?
No, I don't think I have any questions. I presented a case to you of lupus as well, causing both pulmonary hypertension and pericardial effusion. I remember that. And my question is, this is a good framework to have, and it's good to keep in mind this association. Would the acuity of her symptoms dissuade from it in any way?
I think that yes, if you're able to establish that, in fact, this is 4 days old. The only form of acute pulmonary hypertension that's 4 days old is pulmonary embolism.
Yeah.
So, yeah, I think it would. You just always have to be cautious because we don't. Right, if somebody's in epigastric pain, nauseous, the odds that we know her exercise tolerance beforehand in real life are probably pretty low. And yeah, I have never forgotten that case. You forgot the leprosy part of that case. Oh my god. Yeah, leprosy, lupus. Oh my gosh.
The pulmonary hypertension was just buried underneath
Yes.
all the skin lesions. Yes, that was a good case.
That was criminal, Noah. Criminal to put such a complicated case. All right, Dan, what do you got next?
Great discussion, guys. All right, let's keep moving. So let's jump into some labs. So the patient's BMP on admission, we have a sodium of 138, a potassium of 4.0, a chloride of 103, bicarb of 18, BUN 10, and creatinine 0.79. The patient's BNP on admission was 188, and the patient had a lactic acid of 16.7. The patient's troponin on admission was 17, and that is where it peaked. The patient's CBC was notable for a white count of 13.9, a hemoglobin of 11.8, a hematocrit of 36.1, and a platelet count of 82. The patient also got a CT-PE, given our concern for a potential PE that could have been driving this, and that did not show any signs of a pulmonary embolism. However, it did show an incidental moderate to severe pericardial effusion, which appeared complex in its attenuation. We also obtained an EKG, which I have given to Yusuf, who has volunteered to kindly share it with the team.
Okay, give me a minute. I'll share that. Can you guys see the EKG?
No, I don't think so.
Yeah, all right.
Anmol is saying no in all caps.
Yeah.
She wants to see that EKG.
And now?
There we go. All right, Noah, your favorite thing in the world.
I actually hate EKGs,
I know.
but that's why I always try and solve them, because it's the only way you get better, right?
That.
So I'm gonna walk through the EKG, and I like to do.
Oh, I forgot to share with you my advice. I know you like to be systematic, but in these circumstances, it's really important to engage in your reflexes because the rest of your life, you're going to have 1 or 2 seconds, and then it's going to get busy. So practice your reflex read, and then you can do your detail. What's your reflex read on this? All right, 5 seconds. Just reflex.
No
All right, what do you
ACS.
notice
That's my
reflex?
reflex.
Okay, yeah, there we go. Beautiful. That's awesome. Okay, cool. Now take your time.
Okay, so it seems to be sinus. I see P waves and I see caresses. The P waves are quite big. They're positive in 1 and 2 and negative in AVR. The QRS complex is not wide. The axis would be slight,
Yeah.
slight right deviation, which would track with right side failure.
Yeah.
The ST segments in 1, I can, possibly hallucinate some small ST elevations.
Yeah. I think it's a
2,
hallucination.
yeah. 2 and 3, maybe slight depressions, like very slight, I don't know. AVR is very hard to determine the isoelectric point just because how choppy it is. It's very choppy. And then we have very low voltages in the precordial leads. We have poor R wave progression. And yeah, it's very suppressed, like V1, V2, very, very, very suppressed.
Mhm. Awesome, Reed. I think it's very hard to distinguish whether the low voltages are the result of the patient's adiposity or the effusion. So a prior EKG, which may not be present, I think would help you distinguish those two things. Take a look at the V1, the rhythm lead, and tell me what you think about the QRS. In the rhythm strip, all the way at the bottom. I know Vinny's zooming in for you at the bottom. So maybe, Vinny, if you can zoom out, I think that would probably be easiest. Yeah, look at the rhythm strip. Look at the QRS amplitude.
It's very small.
And does it change?
It does. I can see the like electrical alternance. I can hallucinate it.
I know, right? It's not quite alternates because it doesn't vary beat to beat, but you can
Yeah,
see
yeah.
the amplitude of the QRS does change sometimes.
I
I don't know
think
the
right there, like underneath V3,
yeah, exactly. Right.
there's a very big one, and then underneath V6, they're very small. So it does change, yeah.
Yeah, I think the strict definition of alternans is requires to literally alternate from beat to beat variation. But gosh, you know, and I think there probably is subtle PR elevation in AVR. But I don't know if that's I think this and the sinus tachycardia. So yeah, awesome EKG that has a little bit of a pericardial story with the low voltages, the AVR, PR elevation in AVR, and then the possibility of electrical alternans, though that would be a stretch, I think, because it's not every beat. All right, Dan, did you want us to talk about the labs?
Yeah, that would be awesome.
Awesome. All right, Noah, what caught your eye with the labs?
What I was calculating before was the anion gaps, because I feel like that's sometimes a good clue, and sometimes we miss it. So her anion gap's 27, pretty high. Lactate is also pretty high, so I was gonna ask for that next. Those were the things that caught my eye at first. The troponins, I was not surprised. Small elevation, seems to be kind of lateral, just consistent with myocardial injury. We don't have a convincing story nor EKG changes to suggest myocardial infarction, unlike other cases that we've seen recently on VMR. So this wouldn't be a patient that would be, anticoagulated, doing aspirin, Plavix, and all that. The platelets of 82 are interesting. There's no good reason for such low platelets. And it makes me think of viral etiologies. I do think thrombocytopenia accompanies lots of viral and tick-borne diseases. I would be interested to see like the differential and the leukocytosis. I think, if we saw thrombocytopenia and lymphopenia in the differential, then it would be a more convincing story for lupus. What do you think?
I think that's a great analysis, and I think that in real life, I would probably make note of the platelet count, put it to a side, make note of the troponin, put it to a side, and then fixate on the lactate given its magnitude.
Yeah.
And so I'm curious how you're analyzing the lactate here.
The lactate is quite interesting because it is very out of proportion. I think Mark said it in the chat. Like, I've seen many patients in shock because I was in the CCU just like a month ago, and I don't recall ever seeing a lactate this high in a patient with like, not supported by anything. So it's very out of proportion. It makes you wonder, yeah, for sure. Because lactate can come from, ischemia. It can come from decreased liver clearance, and we didn't get any LFTs. It can come from drugs and medications, which is not on. Yeah.
Spot on. I think that the question of lactate is to ask: is this a lactate that's being produced by the lack of oxygen making it into the tissues, i.e., a type A lactic acidosis? Our reflex is to use the blood pressure as a proxy for whether that's true or not, and to say in somebody who's normal or hypertensive that that's not possible. But let's remember that oxygen getting into tissues is a function not of just the arterial pressure, but actually the transcapillary pressure. So if I have a phenomenal arterial pressure perfusing the right side of my face, but I have a massive roadblock here on the venous side, my transcapillary pressure will be very poor. And so the two instances where you can have a markedly elevated lactic acidosis due to tissue hypoxemia, even with a normal blood pressure, are one, you have local ischemia like mesenteric ischemia, where there is destruction of the tissues that's not in proportion to the systemic blood pressure. Or you have such high venous pressure that your transcapillary pressure is very, very low. And so normotensive cardiogenic shock, or even hypertensive cardiogenic shock, is the entity that is potentially at play in this patient, where the patient has such high elevated venous pressures that there is not enough tissue flow across, despite her very impressive arterial blood pressure. However, at the same time, you might wonder, wait, okay, this patient might have normotensive cardiogenic shock, but why is her creatinine completely normal? Why is everything else fine? And so you'd have to pursue that hypothesis by actually probably having to do more advanced testing to see what her perfusional pressure is, and a mixed venous oxygen saturation would answer that question for you as an example. But at the same time, it's also really important to run your list of emergent causes of a lactic acidosis that have nothing to do with perfusion. And so, for example, if your mitochondria are poisoned because you have cyanide toxicity, you don't care what the blood pressure is. Or if your mitochondria are not working because they don't have an essential mineral, thiamine, that would be really, really important. So there are a subset of diseases that are emergencies under the category of non-hypoxia or type B lactic acidosis. And thiamine deficiency is one of them. And there are a couple of others that I think we can probably revisit, not to get too esoteric too quickly, as we go down this. So what I'd be thinking, is, do I need to augment this person's cardiac flow by essentially removing this pericardial fusion to allow her to perfuse and to see what happens after that? And if her lactate remains elevated despite offloading her pressure, I think we'd have to strongly visit the type B lactic acidosis diseases and try to see, can we pin those with her platelet count and with her troponin. All right, Dan, tell us more, please.
Yes, great discussion. And no, great job with that EKG. That was awesome. That was great. All right, we've got 3 aliquots left. Let's get into some imaging. So let's start with the patient's echo. So the patient had a normal systolic function with an EF of around 60 to 65%. The patient was noted to have a mildly increased wall thickness that was consistent with the concentric hypertrophy phenotype, along with that significant pericardial effusion that was visualized throughout. Additionally, the patient was seen to have a large and mobile mass that was present in the right atrium that was shown to traverse the tricuspid valve. This mass was also seen in the right ventricle. The patient, after getting this echo, did undergo a pericardiocentesis. with 1.2 liters of fluid removal that was bloody in appearance. That fluid was then sent for analysis. Additionally, the patient also obtained a cardiac MRI, and I have an image of that cardiac MRI that I think would be great to share with the team as well. And I will pause there.
All right. Maybe no, I'm really curious. While we work on getting the image up, what an incredible aliquot. What are you thinking about the cardiac mass? What is your DDX?
Yeah, it's kind of crazy that we on the last aliquot we didn't even mention the pericardial effusion, which is like complex and attenuation. And now that when he said there was a mass, right? So what is causing the pericardial effusion? We never talked about it. We just like focus on the labs, and which is fair because we do have to manage this patient who has lactate of 16, and then like the diagnosis is pushed back. So I felt like it was a very real life way that we would discuss this case. But now with the mass, and I'm looking back at the family history of mother with triple negative breast cancer, I'm wondering if this mass could be a malignancy, and the one I would be most concerned of, given age, base rate, and the family history, would definitely be breast cancer. Although I do think it's I don't think I've ever seen it causing a pericardial or a heart met. I wouldn't be terribly surprised because breast cancer can be very severe and can have a different presentation. But yeah, one case that we can talk about primary cardiac malignancies like lipomas, sarcomas. There was one very sad case that I saw, which is angiomyosarcoma with similar presentation, intracardiac mass and pericardial effusion. It's a very aggressive, very sad story. But that's where I'm thinking, that's where I'm heading. And I just want to make clear, that the mass, it is a very helpful thing in my differential diagnosis for pericardial effusions, because I wouldn't expect that to happen with infection or autoimmune causes for that matter, unless the mass isn't a malignancy and it's a clot. And then there's another way of connecting those dots with like an intracardiac clot and pericardial effusion and thrombocytopenia, maybe lupus. Yeah. So those are my reflex thoughts, kind of all over the place, a little bit rambly, but it's a very complex case for sure.
For sure. No, I want to give Dan the time at the end to sort of reflect on this. And so I'll reflect very quickly with you because I know we have 2 aliquots to go, which is the differential diagnosis of a cardiac mass, as you said, is 3 things. It's cancer, clot, or pus. Pus is our first consideration when the mass is found on valves, endocarditis. The fact that this is a valveless mass and is mobile raises concern for clot or cancer, which is best distinguished on cardiac MRI. And the cardiac MRI will be able to tell you with a high degree of confidence whether this is clot or cancer, and that distinction is going to be very important. We were speculating a long time ago as to the duration of this syndrome, and the ability for the pericardium to hold 1.2 liters of fluid requires a tremendous amount of time. This story is not 4 or 5 days old. It might be 4 or 5 weeks old. Regardless, whenever something, a clot or cancer, makes it to the right side of the heart, the origin may be from the legs in the form of a DVT, but whenever you catch even a clot or a cancer in transit, the probability of an intra-abdominal source becomes much higher. So 5% of all PEs come from inside the belly, 95% from the legs. But when you actually catch the clot, even if it's a clot in transit, a probability of an intra-abdominal source skyrockets. So no matter what, we actually, in fact, probably will need to look at this person's abdomen with her chief concern, not because of what we think that her pain was, but because whenever you see something in transit in the heart, you have to think that it came from the abdomen, either as a malignancy or a tumor, or finally, both, a tumor thrombus,
Yes.
a piece of tumor floating in them. So
Like the case that we saw with the renal cell carcinoma presenting as IVC thrombus. And I wonder if the lactate, such high lactate, is another powerful clue to the etiology, like, because if you have like malignancy, you can have lactate production, and that would explain why her lactate is so elevated, and she's not shocking. Very cool.
Very, very interesting. Yes, the Warburg effect. When cancer goes to war with your own body. Dan, maybe for the sake of time, we can take a look at the MRI at the end. Maybe you can just tell us to read now, because I can sense that your by the way, your body language is amazing. You're like telling us to move on. There's a lot of data coming, so I'm noting that, and we'll honor that. So why don't we look at the image maybe at the end and get
Perfect. Let's do it. And just the key takeaway point from that MRI, it was obtained after the pericardiocentesis was done. And now the ejection fraction dropped from the initial 60 to 65% on echo down to 30%, as seen on the cardiac MRI. Additionally, there was a mass that was shown to fill up roughly 50% of the right atrial cavity and extending significantly up to the base of the through the base of the right ventricle. Like the team discussed, we also got a whole body PET scan because there was a concern for underlying malignant process. It did show a focal radiotracer uptake in this right atrial soft mass, along with several sub-centimeter pulmonary nodules. Additionally, the pericardial fluid that we sent out actually came back negative for any type of malignancy. And I will pause there. The next aliquot will reveal the diagnosis, and we'll go from there.
Dan, that was absolutely awesome. Thank you for that key piece of information. And I'll just reflect on one thing, Noah, just to follow what we talked about. You see how the pericardial effusion contributes to the ejection fraction?
Yes.
You're seeing that effect here. And so that's just a nuanced point to bring up, but it's not, I don't think, a clue to the diagnosis. So yeah, how are you putting this together? Where do you think the answer lies?
Yeah, I don't know. It's a very interesting case, and if the pericardial effusion is negative for malignancy, I wonder if it's just from pulmonary hypertension and compensatory effect, like you said. With a negative PET, like otherwise, it does make a compelling point for a primary heart malignancy, which is so unusual. And I think just because of how unusual it is, I am thinking of it, but I'm not convinced. I do think a primary malignancy, like in real world scenarios, right? Primary malignancy that's hidden with a tumor met would be more likely, just because of base rate and epidemiology. But since it's CP Silvers, I do think that like something like a sarcoma, like an angiomyosarcoma, like I said before, could be a good like unifying diagnosis.
I don't mean to interrupt you, but I just realized we actually have maybe 7 minutes before the teaching point. So why don't we take the opportunity to give you more time to think and just do a 3-minute breakout room? And feel free to join one. I would love, this is probably such a rich case of people have so many cool thoughts. So let's literally do just 3 minutes of a breakout room. We'll come back. We'll hear your coalesced thoughts after you like sit and think through them, and maybe chat with folks in the breakout room. You're with Deborah and Vinny, so you're in good company. Okay, so 2-3 minutes, and we'll be back. Okay. All right. Welcome back, folks, as evidenced by nobody wanting to come back before the time was over. All right, Noah, you got some time to crystallize it, which I think is very, very key. Yeah, how are you thinking about this now?
Yeah, so the way I'm thinking is that this is a 26-year-old female, so pretty young, with family history for breast cancer, presenting with a right-sided intracardiac mass with pulmonary nodules causing right-sided failure. And we were talking in the breakout rooms, and we do feel like the pulmonary nodules could represent embolization from the cardiac mass. Could also represent other sites of meds from a different primary, so meds to both the lungs and the heart, and then breast cancer would be an obvious choice. I'm not familiar, and I'm not very familiar with breast cancer patients. I haven't taken care of many, and I do wonder if the lack of, an obvious mass would dissuade us from this hypothesis. I do think that for it to cause such severe metastasis, I would expect the primary to be more obvious, right? That's where I'm heading, and yeah, I'd love to see the MRI.
Yeah, I know. I completely agree with you. I think that, you know, you're analyzing this case, and we started off with the pericardium. You want to understand, why is this pericardial effusion happening? And I think that you have two possible answers. The first is that the mass is actually invading and occupying the pericardium, and whatever is the mass is in there, or that the mass has caused such high coronary sinus pressures that the mechanism we had invoked for pulmonary hypertension is at play in an unusual manner. So I think you're right. You're essentially saying that whatever this mass is will tell me what the disease is, and that's absolutely superb. And we talked about what the mass could be. Could be either a clot, cancer, or pus. And I think that the fact that it embolizes to the lungs, well, the fact that it's not valvular makes it either clot or cancer. Clot can embolize into the lungs, but what's really interesting about the embolic phenomenon here is that they're not appreciated on CTA, that they're really microemboli. So I think that, along with the absence of thrombosis anywhere else in the body, would really prioritize this being cancer. And I'm right there with you now, wondering what this cancer might be. And so taking a pause to say, what else are clues? And I think the family history of breast cancer is a clue. Unfortunately, the prevalence of breast cancer may mean that it's a true and unrelated finding. Because if you had a family history of a very rare tumor, I think that would give you much more impetus to invoke that. But since breast cancer is so common, it becomes a question of, is it true and unrelated? So what about the platelet count? Is that a clue? And I think the platelet count just actually was a hidden clue that there's a hemodynamic problem. This is no different than having thrombocytopenia that you might have seen in the CCU with an intra-aortic balloon pump, where because of the turbulent flow in the cardiovascular system, there's a consumptive process causing the platelets. And the question is that consumptive process a clue? And let's hold on to those two things. So what causes a right-sided cardiac mass? The vast majority of right-sided cardiac cancers are metastatic diseases. In fact, the vast majority of cardiac masses, full stop, are metastatic disease to the heart. So what happens when you get a whole body PET-CT, you find no other focus except in the lungs, and the lungs, you come to the conclusion that actually the lungs is metastatic from the heart. Then you have to start to wonder and say, is this a primary cardiac mass? The vast majority of primary cardiac masses are benign. Myxomas and fibroblastomas, they almost always exist on the left side of the heart, a left atrial myxoma and a left fibroblastoma. So a isolated right-sided cardiac mass is very ominous for a primary cardiac malignant tumor. The most common cause, sarcoma. Second most common cause is a lymphoma. The clue to a lymphoma would be, if the lactate persisted, you would probably say, I think this is the Warburg effect. And the persistent lactate is a clue that this is actually primary cardiac lymphoma. What would be a clue to a sarcoma, potentially an angiosarcoma, is the hemorrhagic nature of the pericardial effusion and the prominent hemodynamic profile of the consumptive thrombocytopenia. It has a name. It's called Kasabach-Merritt syndrome. When you have turbulent flow through a vascular tumor, you essentially have a MAHA through it. We don't have overt Kasabach-Merritt here with schistocytes and a hemolytic anemia, but the thrombocytopenia might be a clue. So ultimately, I think whatever this mass is, which you'll probably need a surgical assessment for, will probably tell you it. And I think odds are, even though there's breast cancer in the history, the fact that the PET really localizes it to the right heart is very, very powerful. But I think ultimately we'll learn a lot from Dan about how he was thinking about this and what progress he made. So yeah, why don't we hand the mic to you, Dan, and then we'll hear from Noah after.
Great. What a rich discussion, guys. There's a lot going on here, but you guys are breaking it down just amazingly. So well done. Let me wrap this up. So the patient did undergo a resection of that right atrial mass, and we were able to send that mass out for frozen pathology, and it showed a spindle neoplasm pattern with the final biopsy, with the final pathology of the read confirming a diagnosis of cardiac angiosarcoma. The patient was then started on a paclitaxel gemcitabine chemotherapy regimen for our cardio-oncology team for 3 weeks on, 1 week off, on and off. Unfortunately, as the patient's disease progressed, she was noted to have progressive bilateral pulmonary nodules with worsening metastatic disease. And ultimately, the patient actually opted to transition to hospice care and passed away about a week after, about a couple of weeks after our time together. But such a rich case, such a great discussion. I will turn it back over to all of you.
Be really, really curious to get your reflections, Noah, and then to hear from yours, Dan. Yeah, Noah, what are your thoughts and reflections?
It's a very sad case, and thank you for sharing. And I hope, her story helps other patients. Regarding the case itself, it was a fantastic case, very well presented. I do think that we did a good job moving through it, systematically. And I have no reflections on the clinical reason as of now. I just want to say it's very interesting how things work, right? Because I do think that if you have a curious attitude, you're going to be exposed to more things. So the only reason why I mentioned angiosarcoma before, and the only reason why I knew about it is because I was talking to my senior and we were just discussing about interesting cases. And he showed me a case he had seen on his intern year, and it was a presentation just like this. So that's how it came up in my mind. And shout out to Harrison, and I'm gonna show him this discussion. He's gonna be so happy that he was able to help me clinch the diagnosis.
That's very, very kind and generous of you to share that love with other people. You did an absolutely awesome job, from the authentic barriers that you were coming up with, the struggles that you were having, but also being able to know that this entity exists and diagnose it is absolutely awesome. So kudos to you. What about you, Dan? What did it feel like in real life? What did you learn from this case?
Yeah, I think for me, a lot of the diagnostic learning, especially came in that first encounter I had with the patient. When I first heard about 4 to 5 days with an epigastric pain, and that as my initial story, my differential was very, very different from where we are at right now. And, looking back, one of the main things I've come to take away is, and this came up in discussion, this process didn't happen exclusively in 4 to 5 days. It perhaps had symptomatic manifestation in the acute period, but it has been brewing for some time. And, I think the lactic acidosis, the concentric hypertrophy, these chronic changes that we're seeing kind of reflect that. And so I think that was a big takeaway for me to, number one, put symptoms into context of the patient's global presentation. And number two, use other images like this cardiac MRI to kind of fit everything in. And number two, it was, especially with these cases of cardiac angiosarcoma, even with aggressive therapy, it can be very, very challenging to adequately address these patients. And so, one of the things I learned from my palliative teammates was the importance of having goals of care discussions with families early on, and making sure that we are not just treating what we're seeing on imaging, but treating the patient as a whole. And I think those were just such big takeaways for me. And it was such a great discussion that you guys had. So thank you.
That was absolutely awesome. I'm just gonna pause the recording real quick.
Yeah,
No,
I'm sorry. I was just trying to show the
I know,
pathology.
I saw. No, I saw. I just don't want your private information. It's okay. It's all good. Don't worry about it. Yeah. Now everybody knows how to get in touch with Vinny. Yay! Everybody message him. Dan, this was a very, very powerful story of zeroing in on the disease, and you went from epigastrium to the heart. And I think for me, a hard part is to challenge yourself in that moment, not to get fixated on the pericardium. And I learned a lot of I'll probably reinforce a lot of like cool edge of the universe things about angiosarcoma and the Kasabach merit and all the subtle clues that that was the answer. But I think for me, the most practical implication is not to get locked into the pericardial effusion and to be very careful of the hemodynamic implications of drainage of a pericardial effusion. Because I think you thankfully didn't see any clinical consequences, but you saw what happened to the EF when you did, right? And so I had probably without I have room to grow by in teaching you all that it's pulmonary hypertension and the elevated pressures on the heart. You can't offload it. But actually, the concept there is anything that is elevating the intrinsic cardiac pressure. So a mass taking up space in the right ventricular cavity, causing RV hypertension, and ultimately stretching the RV muscle and getting that counter push from the pericardial effusion. That's another reason. So I think if I were taking care of this patient, I'd want to remember to be super careful before draining this effusion. And it's not just that there wasn't any pulmonary hypertension, that there shouldn't be really any cause of intrinsic ventricular hypertension to be careful of removing that effusion. So that's a really, really powerful tale. And for those of you interested, there is actually a catastrophic syndrome of called a post-pericardiocentesis syndrome that this patient was probably on the spectrum of when you remove the fluid and the patient can actually have hemodynamic collapse. So I appreciate both the incredible like just sort of narrow edge of the universe knowledge of angiosarcoma and what it can do, but also just the fact that you allowed us in 6 aliquots to really go from basic to esoteric in such a gentle flow. I really appreciate it. And a big kudos to you for honoring this patient and sharing the learning with us. Huge thank you to Vinny for scribing today. And it's now time for Pearls with Parisa.
Thank you, everyone. It was a phenomenal session and discussion. I'm so honored to be part of that. We started with a patient who presented with abdominal pain, and we have a famous mnemonic of VPO, which is including vascular inflammatory perforation and obstruction. And we know that we need to apply that specific things for each single organs. And this specific patient has her pain had pleuritic nature. We needed to emphasize, put our center of gravity to lung and specific to pericardia. And the clue we had specifically in the beginning was lack of vomiting. We needed to we specifically know that we needed to emphasize to something outside of God, why I'm getting so confused, I don't know. Anyway, we also have cough from hoarseness plus hoarseness and nausea. We needed that. We know that these are this could be autoimmune plus post-infectious causes. This patient has hoarseness following URI. We know that this indicate a space occupying lesion in mediastinal or pericardium that could compress the recurrent laryngeal nerve, and this symptom could radiate to neck. We also know that acute pericardial condition that could progress to hemodynamic instability. For example, this patient had her other vital signs were normal, but she has a distant neck vein. These are the clue for us because this specific patient could decompensate so rapidly. We also talk about isolated right heart failure, and the reason for that could be pulmonary hypertension, tricuspid regurgitation, tricuspid stenosis, serotonin syndrome, and pericardial effusion. And we also talk about sinus tachycardia that could indicate serious underlying condition like pericardial effusion or pulmonary hypertension, and we need to evaluate pressure overload. We also know that when evaluating pericardial effusion, it is essential to consider pulmonary hypertension as a potential underlying causes, and it could be they could have interrelationship. And when we are having severe pulmonary hypertension, pericardial effusion, actually it could be compensatory mechanism for that, and pericardial specifically could hold 1 to 2 liters of the fluid. We talk about the thrombocytopenia, that the reason for that could be viral, tick-borne disease, lupus, when it is accompanied with lymphopenia. We talk about a high lactate reason, which is ischemia, decreased liver clearance, and some kind of the drugs. We also talk about it. We have a different approach for that. For example, in type A hyperlactatemia, the reason is we could approach it as a capillary pressure. It's our indicator. We have a high venous pressure or low arterial pressure, or the other type of hyperlactatemia is type B. We need to go beyond pressure related causes. For example, in this case, we didn't have a high creatinine or low arterial pressure. We need to think about thiamine deficiency or cyanide toxicity. We talk about the different causes for cardiac mass, which are cancer, clot, or pus. We are specifically talking about endocarditis. When we have a mobile mass, we need to think about clot and cancer, and cardiac MRI could help us to differentiate between cancer and clot. Clots in the cardiac, in the heart usually originate from the leg. There is so rare, 5% when they are originating in the abdomen, and they could be tumor or thrombus. When we are having pericardial effusion, they could be invasion to the pericardial space, or they could be because of the high coronary sinus pressure. When we are having right-sided mass, it could be because of the metastasis to the heart, or it could be primary cardiac masses because of the myxoma, fibroblastoma, or lymphoma. When we are having lymphoma, we could see Warburg effect. Rabih also mentioned the very cool syndrome at the end, Casaubon-Merritt syndrome. When we are having angiosarcoma, vascular tumor, something thrombocytopenia, it's happening because of the turbulent flow in the tumor, and schistocyte plus hemolytic anemia, it's happening. Thank you so much, everyone.
Wow, oh my gosh. Are you tired? A little bit? That was
Sorry, my
rude.
tongue twisting having and my husband is talking over there. Sorry.
That's okay. That was absolutely superb. What an incredible hour and 15 minutes. Noah, that was so cool that you were able to lock in and get the DX. Dan for an absolutely incredible case. Vinny for Ole Gunnar Solskjaer, who only you will get that reference. And Pearls with Parisa. Thank you so much. What an enriching time, and hope to see you guys next time. Thank you.
Thanks, everybody.